So good morning, everyone. Welcome to our Health Choice Network Alliance Chicago weekly webinar series on COVID-19. The webinar will be starting shortly. If you could, please put yourself on mute, and we will join the webinar all together very shortly. So as part of today's interactive webinar, we will be asking you to take out your cell phone and text in the line 22333, and then in the message put in COVID-19 heroes. And our word cloud question of the day is, what is one successful intervention that your health center has done this week for COVID-19? We'd like to hear your stories. Please let us know. Our webinar will be starting shortly. This is co-hosted by Alliance Chicago and Health Choice Network, preparing communities for COVID-19. This is our 5th session. Today's topic will be on special populations, and we'll be starting the webinar shortly. Please hold on. Today's webinar will have some interactive chat function. If you want to ask a question of any of our speakers, please put your name and health center with a short, direct question to the speaker in the chat function. We will be reading some of the questions during the webinar, and some of them we will collect and put out frequently asked questions later. The live polling function of today's webinar, please pull out your cell phone and in the line text 22333 and put in the message box, COVID-19 heroes. You'll receive a message back, and after that, you're all set to go to participate in our live polling instructions and this week's word cloud. And this week's word cloud question is, what's one new successful intervention that your health center has done this week for COVID-19? We hope you can join us in this interactive portion. The webinar will be starting shortly. The webinar will be starting shortly. Preparing Communities for COVID-19, Session 5, hosted by Alliance Chicago and Health Choice Network on special populations. We'll be starting shortly. We will have some interactive portions of today's webinar, so please have your phone ready, and we'll give you instructions and the question for this week's word cloud in just a moment. Welcome. For this week's webinar, our live polling instructions. Please get out your cell phone and in the to line, type in 22333. In the message line, put in COVID-19 heroes. You'll receive a response back, and then you're all set to join our live polling function and also our weekly word cloud. And our weekly word cloud question is, and please keep your answers short if possible, what's one new successful intervention that your health center has done this week for COVID-19? We'll be collecting your innovative interventions on this word cloud, and we'll be showing them throughout today's webinar. We'll get started in 1 minute. We're just going to allow for a couple other people to join today's session on preparing communities for COVID-19. And we want to thank all of our community health center heroes, and we're ever thankful for standing behind these healthcare heroes during this time. For today's interactive portion of the webinar, you may ask questions in the chat function. Please put in your name, health center, and then a short directed question in the chat function. We will attempt to get to them during the webinar or get you the responses later. So as we get started for today's webinar, the live polling instructions are here. We would like to know what's one new successful intervention that your health center has done this week for COVID-19. Please put in a short response. And as we collect these now and through the webinar, we'll understand a little bit more what everyone is doing for COVID-19. So welcome everybody to today's webinar, Preparing Communities for COVID-19, Session 5. We're going to be focusing on special populations. Today's webinar series has been hosted by Alliance Chicago and Health Choice Network. We're happy that you can join us today. We have had about 370 registrants for each of our 5 series, and we hope that each one of you can ask some questions and contribute to the online conversation. If you could join us for our live polling instructions, we will have polling questions throughout today's webinar. Put in 22333 in the to line, and then put in COVID-19 heroes in the message line to receive a message back, and you're all set to start our live polling instructions. So good morning, everyone. My name is Tim Long. I'm the Chief Clinical Officer for both Health Choice Network and Alliance Chicago, and our team who's putting this on would like to know what's one new successful intervention that your health center has done this week for COVID-19. We have a lot of great things going on at health centers across the country. We want to both tell our story and learn from each other. And as we start today's webinar, we'll be coming back to this word cloud to see what other health centers have been doing this past week. As we start preparing for communities, today's agenda will focus on special populations. But first, we'll hear from the CEO of both Alliance Chicago and the CEO of Health Choice Network. They'll give us some words on a national level of how we're going to participate moving forward. Then we will hear from 5 distinct health centers from across the country, each focusing on their own unique special population. And then, as always, we will wrap up with some next steps, and hopefully we will have some resources and some questions that we will be able to have answered. So first up, we're going to hear from the CEO of Alliance Chicago, Dr. Fred Rockman. Fred, are you with us today?
I am. Thanks, Tim. Can you hear me?
Yes, perfectly, Fred.
Perfect. Thank you, Tim. So good morning, afternoon, everyone, depending on where you're calling from. Thank you so much for taking time out of your hectic week to join us. I really do look forward to these Wednesday sessions tremendously, and we really hope that they are valuable. So as you are in the trenches doing your hard work, we're trying to take the pulse and try to see what we can do as a network in our collaboration with Health Choice Network to see what it is that we can do at a sort of system level to support all your work. Our focus to date has been on creating shared learning opportunities and access to expertise. These webinar series are an example. Helping with access to resources, those are both physical and financial resources, as well as expertise. Developing informatics tools and workflows to help improve efficiency and data capture. Supporting your rapid deployment of virtual care tools and approaches to using them, while at the same time planning for more enduring comprehensive telemedicine infrastructure. And hopefully many of you have applied for FCC funding to do that. If you could just go back for a second. And lastly, aggregating data to guide population management, service planning, advocacy, and documentation for payment. And one of the real things that we feel we have to contribute is we have staff that are spending their time really just looking at trend data, aggregating everything, as trying to assimilate all the information as the pandemic unfolds, both on the data and statistics and the policy front. It's been a tiring 5 weeks, you all. Hard to believe this is our 5th session. And I know everyone's exhausting, but the social distancing and measures we've been taking appear really to be working. If you have been looking at the data, it appears that we are either approaching or actually just at the peak. And we're hoping that we'll begin to see a downtrend in the statistics. Next slide, please. And what that means is attention is beginning to turn now to how we plan for next phases of the pandemic. If you have not had the opportunity to read this Scott Gottlieb piece, I really urge you all to read it. We'll be including the link in our materials. But it's a very, very thoughtful overview of the pandemic from our crisis phase now all the way through to how we wrap things up and return to a normal life. It's a very, very good framework from which to be operating and to try to lift our heads out of the crisis mode that we all have to be in. Next slide, please. The Scott Gottlieb's piece contemplates that there are basically 4 phases, The first is one that we're in, which is to slow the spread of the pandemic. The next phase, though, is to begin reopening state by state and to begin to roll back the extreme social distancing measures that we're under now. That then would lead us hopefully to a third phase where we can have established protections for everyone and lift all of the restrictions and really return, as we all yearn to a normal, more normal life. It does not end then, because then we have a lot of rebuilding to do and some readiness for the next pandemic. We always want to be prepared for the next emergency. Next slide. So in order to move into this next phase, and you're beginning to see each state beginning to start to put together plans for moving out of the current state, these are the things that we need. We need better data to identify the areas of spread and understand the rates of exposure and what percentages of our populations are immune. We definitely need, and have learned we need, improvements in our state and local healthcare system capacities, the public health infrastructure, but I'd also put to you that we as safety net organizations are a very, very important infrastructure in order to continue to do early outbreak identification, case containment, and making sure that there's adequate both medical supplies and medical care capacities. And finally, we are definitely going to need advanced treatments. We're going to need to move to where we have prophylaxis, treatment regimens, and better informed medical interventions. Next slide. Very, very specifically, if we look at your individual states, these are the conditions that are suggested need to be in place to really responsibly consider reopening. A sustained reduction in cases for at least 14 days, hospital and acute care facilities able to handle the caseload, an ability to test patients with COVID-19 symptoms, all patients, and able to conduct active monitoring of confirmed cases in their context. And we're beginning to have these capacities, but hopefully all of you know that we're still trying to get there. So I want to end with a call for us as health centers. And that is, we've done a lot of rapid learning that has really advanced things that we've been talking about for years in changing our model and our delivery system. Now is the time to convert these rapid emergency responses that we've done to rapidly put those things into place into a more planful, future-oriented infrastructure, and that work should be beginning now. We should accept the challenge to work as a comprehensive system rather than a collection of disconnected individual organizations. And Health Choice Network and Alliance Chicago pledge to redouble our efforts to help you achieve that important goal. And finally, looking at the statistics and the sad disparities in how COVID-19 has impacted our population, to champion the mandate to protect those who are vulnerable and to eliminate health disparities. And that leads us to our session today, focused especially on vulnerable populations. So thanks. With that, let me turn it over to my colleague, Alex. And
good morning, everyone.
Thank you, Brad. I appreciate those.
Sorry, Dr. Long.
No, go ahead, Alex. We're ready to hear from you. I apologize, stepped in.
No problem. Good morning, everyone, and thank you for joining us. On behalf of the Health Choice Network Board of Directors and our ACO Board of Directors, which are the CEOs of our health centers, we are so honored to be with you on a weekly basis as Fred mentioned, to support you. You have always been our healthcare heroes. This year, I'm celebrating 21 years of being part of the health center movement, and I'm always at awe at the innovation and the dedication to mission and communities that health centers show day in and day out. As we talk about the special population, and Fred framed it perfectly, it is really important to me as being a rural migrant seasonal farm worker advocate for almost 20 years now, and now serving on a foster children's care program board of directors. I can tell you the ramifications of COVID-19 are way beyond what we expect of this flattening the curve. We have children with special needs, learning disabilities, physical disabilities, that are being left behind primarily because we were not ready to self-quarantine and be home. And the challenges that our health centers will be facing with our special populations seems to be a surprise to our acute and managed care partners, where health centers have been dealing with social determinants of health. And so when I hear the governors of each of the states, the health departments, and the acute facilities with our managed care partners talk about how it's surprising that our African American populations, our Hispanic populations, and those that have limited access to support, they're in the middle of food deserts and can't get their hands on PPEs and have to work in industries that require close contact. It is always impressive to me how health centers have been the voice of having these social determinants of health and raise the bar when it comes to treating our communities. So one, I want to say thank you. Two, a huge shout out to the Alliance Chicago, Dr. Long, and all the team that worked so hard to put these on a weekly basis. I too look forward to these on a weekly basis. I love the fact that our health center partners that join us week in and week out are driving the topics that we're bringing to your attention. And I want to thank all of the providers, physicians, health F2HCs that are joining us as panelists. Some of you are my heroes for so many years, so thank you for the work you've done. I know you're tired, I know you're stressed, and the fact you've taken a small time out of your schedule to be with us and share your best practices and what you've seen on the ground is truly remarkable. So on behalf of Health Choice Network, I want to say thank you, and thank you, Dr. Long. I'll hand it right back to you.
Great, thank you, Alex. Thank you for those words. Thank you, Dr. Rockman, also for those words, and we appreciate all the work that the health centers are doing, but also at the network level, both Health Choice Network and Alliance Chicago, to help our health centers move through this period. So our first interactive polling question, if you can get out your phone. Black Americans represent what percentage of total COVID-19 deaths in the states? There's 42%, 34%, 25%, and 13%. And we're going to give it just a moment before we cut over and close the poll. Again, this is on your cell phone, typing in 22333, putting in the message line COVID-19 heroes, and you'll get a response, and then you're all set to go with this and our other interactive polling questions throughout today's webinar. And why don't we go ahead and close the poll for now? And it looks like we are still jumping. So the answer actually is 34%. So according to the next slide, according to the CDC, we do have 33.7% of individuals are Black or African American who have COVID-19. And while Black Americans represent only about 13% of the population in the states reporting racial and ethnic information, they account for about 34% of the total COVID-19 deaths in those states that are reporting. So that is our first interactive poll. And now we're going to hear from one of our close colleagues in Florida. Dr. Lawrence is going to talk to us about activities going on at Jesse Trice Community Health System. Dr. Lawrence, are you with us?
Yes, I am. Can you hear me okay?
Yes, we can. Thank you.
All right. Hello to everyone, and thank you for having me. We can go to the first slide. I wanted to say that in the beginning of this epidemic, COVID-19 was an illness that knew no boundaries, but of late, it's now recognized as one that has impacted certain populations more so than others. So it's not news that African Americans with COVID-19 are dying at a higher rate than others who've tested positive for the disease. Many of you probably, at least here in Miami, probably saw an article in the Herald over the past few days that stated that this is a key finding that's not necessarily that obvious in the Florida Health Department's daily reports on the coronavirus pandemic. There's also the opinion that this indicator of COVID-19 affecting certain populations more so than others should help to drive the state's response in minority communities. In Miami, which has the most confirmed cases in Florida, African Americans who tested positive for the disease have died at a rate of 4.6%, compared to a rate of 3.1% for whites and 1.7% for people whose race is classified as other. And this is according to Health Department data. So I'm sure that we all know that these stats are because of the social determinants of health, where we live, work, and play. Many live in multiple family dwellings that may contribute to a lack of social distancing, work in jobs that aren't able to be worked remotely, and have higher rates of chronic illnesses such as hypertension, diabetes, and asthma. And Miami is not the only city. Similar and higher rates are noted in others, such as New York, where you can see that over a third of the cases are in the Black population. And I won't go over all of the details in this graph, as I'm confident that you will see it again later in our discussion. I do want to note that the Hispanic population ranks second, actually, to consequences from COVID-19, including hospitalizations and deaths. The other places experiencing these types of stats are Wisconsin, Louisiana, and Kansas. So our cases here in Florida continue to increase and may be higher than that being reported. DOH reporting in Florida may not adequately reflect the extent that COVID-19 has impacted various racial groups. And this is in part due to the fact that DOH does not report on results coming from private laboratories. The next slide. These staggering figures do indeed represent a strong and emergent reason to address certain populations. At Jesse Trice, we're striving to reach our community by offering testing and addressing various social determinants of health. We cater to more than 46,000 patients annually, with the majority of our patients, about 60%, being Black and about 35% being of Hispanic origin. Over the years, the majority of our visits have been made by females. A lack of clinical care or continuity of care may compound the fact that males actually have more severe consequences from COVID-19 than females. 40% of our patients live at or below 100% of the federal poverty level. In the prior year, we had more than 3,500 visits for diabetes, nearly 5,000 visits for hypertension. So those are our stats for our clinical encounters, but when you look at the drive-through testing being conducted at Jesse Trice, which is open to the community, it's noted that the bulk of patients receiving testing are of Hispanic origin, which is good in that we're reaching a vulnerable population, but we're not reaching the most vulnerable. The younger tend to seek testing more so than the older, and not the greater than 65-year-old population that's being encouraged to seek testing and is most vulnerable to it. Also noted is that more females are receiving testing, about 55%, compared to males. So you can see that more is needed to address racial disparities so that we reach the African American or Black population and the Hispanic population. The next slide. So Jesse Trice started drive-through testing on March 16th. Since this time, we've tested about 300 patients, of nearly whom 20% have returned positive for COVID-19. In addition to drive-through testing, patients are able to walk up as well. A tent actually is being acquired that accommodates specifically for walk-ups through window testing. And we believe that walk-up testing is crucial to our community since a high percentage of our population relies on transportation services. In years past, 74% of transportation requests were made from the elderly. 32% were from parents with children. And we would love to accommodate a higher number of patients, but a lack of testing supplies is a huge barrier. We're currently working with other agencies to acquire additional test kits. As of April 16th, more than 600 patients have been screened via telephone, and these screenings are being done based on CDC guidelines, focusing on those with symptoms. We also offer repeat testing to patients who previously screened positive at the Jesse Trice drive-through. And this is crucial because a lot of our patients are eager to get back to their places of employment. One of the things we're noting is that frequently patients are retesting positive. We think that it may be just the kids picking up virus particles that are left behind. Next slide. Other things that we're doing for our patients is telehealth. We're using telehealth for a number of reasons, and not just because CMS made it easier for us, although that's an important one. We've had a telehealth platform for some time and used it in some limited circumstances, but now the use of telehealth has been critical to our ongoing operations. So we're using it to provide ongoing care to our patients with chronic illnesses, for behavioral health, for patients who are self-isolated with COVID-19 symptoms or who have tested positive and need ongoing care for chronic conditions. We're using it for teledentistry, especially for our pediatric population. We're using it for a virtual walk-in clinic, for acute care, and for nutrition services. Other reasons include integrating care where we can offer patients behavioral health sessions during their primary care virtual visit with our providers. Our providers have noticed the added stress that our patients are faced with and their need to deal with this even before we can get their medical needs addressed. Other things are that we're establishing virtual small groups for continuation of our hypertension and diabetes small group classes. Our managed care office is also coordinating with our seniors to do virtual exercise classes. One of the challenges that we have is in providing assistance to our population with getting registered for telehealth, especially for those who are not necessarily tech savvy. Next slide. We have an opportunity in that we have a presence in 40 schools, and all of our schools currently are out of session. So what we've done is to deploy some school-based staff to our community-based sites to assist with our screenings and drive-through process. Others are assisting with temperature screenings and ensuring all are wearing masks prior to entering our offices. Our school-based social workers are busy making calls to parents and children who had open cases while school was in session. They've also assisted families who've had members who've tested positive for COVID-19 or have lost jobs and need to know of available community resources. Thus far, our school-based social workers have made over 400 phone calls and telehealth visits to families. We also have a partnership with the Florida Department of Health for an open airways asthma program. So even though school is out, we are in the midst of reaching out to those families to offer virtual classes. Those are our social workers pictured, but obviously this was before the COVID-19 era when social distancing was not a factor. And next slide. Other things that are needed when we consider what we need to continue to address COVID-19 and other issues arising as a result of it, we're working to acquire additional testing supplies, to develop creative ways to conduct outreach efforts since social distancing makes it difficult for our outreach workers to pound the pavement. We've also collaborated with FarmShare to provide food to our senior citizens. We're trying to overcome challenges associated with convincing our population to register for telehealth. We're addressing chronic conditions and assisting patients with acquiring tools needed so that they may self-monitor, and assisting our staff with acquiring tools needed to remotely monitor patients' BP and glucose readings. And last, we know that there's a need to ramp up behavioral health services for a population clearly faced with challenges of pre-existing social determinants that are now compounded by COVID-19. And with that, I will say thank you.
Thank you very much, Dr. Lawrence. We appreciate all that you do and also all that your team is doing at Jesse Trice. We appreciate all the efforts and appreciate you joining our webinar and speaking today on your experience at Jesse Trice. So we're gonna move. We have some questions in the chat which we're gonna collect, but we're gonna hold them for right now. I'm gonna make sure that we can get through all of our 5 speakers. So if we advance the slide to our next polling question, again, take out your phone and put in 22333, and in the message line, put in COVID-19 heroes. And the next question is, how many billions of dollars are needed to accommodate 400,000 new shelter beds for the homeless? 11.5 billion, 4.5 billion, 2.7 billion, or 1.3 billion. We'll leave this open for just a moment. So how many billions of dollars are needed to accommodate 400,000 new shelter beds for the homeless? And why don't we hold it right there? And the answer is correct. 39% have said 11.5 billion dollars are needed, and that is correct. So according to the Homeless Research Institute, they concluded that 11.5 billion is necessary for those 400,000 new shelter beds and to ensure appropriate social distancing and the creation of quarantine locations for the sick and exposed. So on our next slide, we're going to hear from our next health center, Charles B. Wong Community Health Center in New York. Dr. Pong, are you with us today?
Yes, I am.
Great, thanks, Barry.
Okay, should I start?
Yes.
Okay, so I just want to say that we are at the Charles B. Wong Community Health Center. We are proud to be part of the Community Health Center family. And here in New York City, one of the big lessons has been your locality and your state departments of health and government really have to take it very seriously, as it can just spin out of control within weeks. So we've really learned that tragic lesson here. Next slide. So I only have 3 slides, and I'm just going to run through it in terms of some race and ethnicity statistics and some speculation. I will frame this that COVID has really revealed the vulnerabilities of the people that we take care of, the vulnerabilities of the system, and of government and its response. And it really shows that we as community health centers are needed now, and I think will be needed even more so in the future. If you look at this slide, these are just poverty rates by race and ethnicity. So it shows non-Hispanic, white, Black, Asian, and Hispanic, and this is 2015 data. Next slide. This is from the New York State. So this is for cancer statistics. So this is where I'm leading to. If you see detection of cancer, you'll see white shows highest cancer rates, but I think that's partly is because of who gets medical care, who gets the most medical care, who gets cancer detected, who gets it detected the earliest. But if you look at the smaller, more intense colored bars, then you will see the death rates from cancer for New York State, and this is 2012 to 2016 data. So you'll see that Black Americans are the highest in terms of death rate, and white and Hispanic, and then Asian Pacific Islanders. So I will touch about on this in a little bit. Why are the cancer death rates lower for Hispanic and Asians if the poverty rates are higher in certain cases? Okay. Next slide. So this was touched upon earlier, and we see data, and I will give thanks to all the people who advocated to get ethnicity and racial data out there, because otherwise this was all hidden. So thank God that people have advocated to get departments of health to release this kind of data, and CMS has not even released this kind of data. So as mentioned before, has really hit in New York City the Black and African American community, then Hispanics, then whites, and then Asians. This is really complex, so this can hide some of the things that we see. So we really need demographers and sociologists and epidemiologists to dig into this, because I think it will really show what we are all thinking in our minds of our vulnerable populations. Like, why is this happening? Where do we go from here? How can we heal the health system? How can we heal our society? What needs to be done? We all do social determinants of health questionnaires. I'm glad that's out there in the public's minds. But at my own health center, I really have a hard time with those questionnaires, because I don't think they capture the depth of the patients that we see and their needs. I guess I should have been part of that group and threw in my 2 cents, because it might answer things. You have a job. Is your job stable? Is your income enough? Can you make it through one paycheck? Can you make it through a month? Can you make it through 3 months? Because that's what's going to happen to our patients now. What stresses are you feeling? How many people, not just do you have housing, how many people are living in your household? How many extended family, how many generations are living in your household? How many people in each room? This is going to be reflected in the statistics that we see on this slide. Where do you live? What is around you? Whether it's markets, supermarkets, healthcare. In New York City, we're close to everything pretty much. We're so dense. But transportation, what transportation do you have? We all rely on public transportation here for the most part. And you see other cities where disproportionately poor people have to take public transportation, and working class people, because that's what's available and that's what they have and we can afford. So then that's going to affect all this in terms of who gets COVID and what's going to happen. So these really complex. I'm going to just go into 2 other points. Taking care of immigrants. So our health center takes care of mostly Asian immigrants, Asian American immigrants, predominantly Chinese, predominantly monolingual. So this really highlights why we exist as a health center. What is our niche? When there's other health centers in the community? Because our patients really, need our language skills, our cultural familiarity. That we don't care what your immigration status is. That we don't ask. That doesn't appear in how we take care of people, and that our patients travel from around the New York City area, predominantly by subway, to get to see us, because they feel they want to see that familiarity, want to feel listened to, and they want to feel that they're going to be taken care of in the right way. I would say a lot of our patients do have what I would call social capital. They do have housing, they do have family and extended family, and they do have a little bit of money or nest egg to draw upon wherever it is, so that they're able to survive. However, in the coming months, it's going to be very hard, as many of our patients are restaurant workers, hotel workers, home health aides, and really not sure what's going to happen economically. The next thing I want to talk about is what I call the healthy immigrant effect. Why are Asians show less effect when this virus is thought to have originated from China? Why didn't it affect our community as strong? I think part of that explanation is that our patients saw the media from China and were much more scared of the consequences and what was happening. They could see in newspapers or television, in their own ethnic media of this, may have had other social media like WeChat or WhatsApp and connections firsthand or secondhand or thirdhand to people in China. So they were much more aware and much more fearful of the virus's effects. Unfortunately, the rest of New York City were not. We relied on the CDC and Department of Health, and we actually thought the people who were saying these things were almost borderline hysterical, saying that can't happen here, but tragically it has happened to us in multiples. So I think when you look at statistics, immigrants are healthier in general because to come as a first generation or second generation, to come to the United States from another country means that you're automatically more healthy than the people who cannot come or who are left behind. So just like Kaiser Permanente can say, we do great jobs with all our patients, and they do, they also have a healthier population to start with because the patients have health insurance, meaning that they all have employment of some type. So for Asians, that partly explains the effects for cancer and also the effects on COVID. Though we have seen many cases ourselves, we take care of many patients. It's horrible. People are it's awful in terms of what people are describing. And even our staff have been affected, and definitely people's friends of friends or friends of friends, family members. I would say that if you look at Hispanic Latino for New York City, I think that means that community is even doing worse, because if they're supposed to be healthier due to this healthy immigrant effect, then the numbers that show up are even more staggering. So then you're like, wow, it really is affecting communities. So that's what I'll say about the statistics. I hope that we as a society can heal, get to really expose and get to what Fred was talking about. Where do we go from here? How can we get to a better system? How can we heal? How can we address these inequities? How can we address these vulnerabilities? And in the health system, I think we're going to start thinking about that next phase. How can we reopen? What will care look like? Can we make the system into what we want at our health centers rather than be told what to do? What will we do to change this? Will it? And I'm even thinking about money. Will this make us move faster to capitation for managed care? Because we're not going to get as many visits. We're not going to get as many walk-ins like we have traditionally have. A lot of people in our community love having that availability for us, but that's just not going to be possible given the new social distancing and new ways that will open in the future. And then the last comment was on integrating telehealth. I think of my kids, and okay, I don't think they talk on the phone to people. They just use their cell phone. So maybe medicine is headed something similarly. I just wonder if we're losing a lot of the richness of our doctor-patient, practitioner-patient relationship. Okay, so thanks. I'll be glad to answer some questions at the end. Thanks for the opportunity to speak to everybody, and hang in there, everybody.
Great. Thank you very much, Dr. Pong, and we really appreciate you speaking today and then giving the experience from Charles B. Wong Health Center in Manhattan. So thank you very much. We have some questions coming in, which we'll try to do later. We want to make sure that we get through all of our speakers. And also, in your handout section, on the side right-hand column of the webinar series, you'll see a section called Handouts. We do have in there today the frequently asked questions from last week's webinar and the answers. so you can download those. We will be putting this slide deck out later today for everyone's viewing pleasure. So again, our next interactive poll is racial and ethnic information is currently available for what percent of the known cases in the United States? Again, you can pull out your cell phone and text 22333 and put in the message line COVID-19 heroes, and then you'll be able to respond to this question. Racial and ethnic information is currently available for what percent of known COVID cases in the United States? 35, 27, 15, or 6? So why don't we go ahead and close the poll. And it looks like the answer is 35%, folks. Not many takers on that 35%. But according to the Centers for Disease Control, dated yesterday, and I think it was from either April 21st or April 20th data, the CDC is reporting that race is specified for 35% of the total COVID-19 cases in the United States. So again, there's some great resources on the CDC website. We would encourage people to go there. And on all of the slides, which will be available later today, there are hyperlinks to all of the data and to all of the health centers being presented in today's webinar. So next, as we move from Miami to New York and now to Chicago, we're going to hear from one of our close colleagues, the Executive Director, Ed Stellan of Heartland Alliance Health. So Ed, are you with us?
Yes, I am. Yes,
Great.
I am. All right. So I'm going to plunge in. I do not have slides today. I was kind of overjoyed by the offer of not having slides, so I went ahead and took that offer. And I also, the way I'm approaching our discussion today is I'm sort of going to tell the story of what we've been doing to address the needs of people experiencing homelessness in Chicago. I'm going to start with talking a little bit about Heartland Alliance Health and what we've done behind the scenes. And then I want to quickly spill out into what we're doing at a more multi-system level and wrap up with what we're finding and where some of the remaining pressure points are. So first and foremost, inside of Heartland Alliance Health, so again, Heartland Alliance Health, we're part of a larger organization called Heartland Alliance for Human Needs and Human Rights. And Heartland Alliance, whether it's here in Chicago or in countries across the world, we're generally working with the most vulnerable populations. So Heartland Alliance Health is a federally qualified health center in Chicago that works exclusively with populations experiencing homelessness. So inside of our organization, on March 11th, I remember sitting at my desk and realizing that some of the issues that were coming up related to our COVID response just could not be dealt with in email. And so I convened twice daily COVID response leadership team meeting. We continue to engage in these. I really look forward to them. Every morning at 8, every evening at 5, and where we plan our day and then learn. I think everyone on the phone will agree with me that it's like drinking from a fire hose, and no 2 days are quite the same. And our response is constantly evolving, and we're learning and pivoting all the time. So inside the organization, you know, we're proud of the fact that we work hard to address the social determinants of health because our folks are homeless. So we, for instance, have grocery centers that on the northwest and south sides of Chicago that provide medically tailored food to people in a grocery center experience. Well, we quickly pivoted and reworked that. And so now we're delivering the food to people in a contactless way. We also have curbside pickup for folks. Our residential programs, we have about 300 units of housing. Some of that is clustered, it's supportive housing, but people live on a single floor in a certain area. And so we closed our community spaces, and we reworked the way people eat. As you can imagine, there was a lot of communal eating. Now food is delivered to rooms, things like that. We are working with a population experiencing homelessness, but we have started telehealth, and the uptake has been remarkable. A lot of people are taking us up on telehealth, and we have found in one corner of our organization, outpatient behavioral health counseling, that the uptake is better than in person. So we're actually having a lower no-show rate and longer appointment times, which I'm surprised about that last one. And we continue to do street outreach to Encampment. So really delivering education. I'll talk a little bit more about our work with the city on that. And then taking a laptop and Wi-Fi hotspot to register people for stimulus checks. It really takes a village to address homelessness. So we've worked hard to activate that village, and we're sort of co-leading. I hardly even want to say co-leading because it's such a democratic process, but co-leading multi-system collaborative that's now called Unsheltered Chicago. It started really with a focus on the west side of Chicago, but it has representatives from government, the Chicago Department of Public Health, the Department of Family and Support Services, academic health partners like Rush University Medical Center, UI Health, federally qualified health centers like Lawndale Christian Health Center that does amazing work in the shelters on the west side, and then Heartland Alliance Health, and of course our shelter partners. So early on, we worked with the city around decompression of shelters so that the shelters could abide by social distancing, and 400 beds were set up in additional shelters throughout the city in one weekend. And encampment support, so hand washing stations were put into the encampments and portable toilets, of course. And this group, the Unsheltered Chicago group, they meet 7 days a week, twice a day. 7 days a week, twice a day, 8 o'clock and 3 o'clock. And they've created a pipeline for asymptomatic people with underlying health conditions who are homeless, so people over 60, people over 55 with underlying conditions, so that they can get into a hotel downtown where they are provided supports. And in addition, working closely with the city, this group was able to stand up a 100-bed shelter for COVID positive people who are homeless, and that is quickly filling. It started last week and is quickly filling. And working with Illinois Department of Public Health and Chicago Department of Public Health, doing a lot of testing and isolation of people within large shelters. And some of those shelters can accommodate isolation because they're so large, they have separate spaces. And so we have helped them set up isolation spaces for COVID positive people within their walls, but separate. To put things in perspective, Heartland Alliance Health, up until about a week ago or so, we were really working with a team of testers who were volunteers from the academic health settings like UI Health or Rush. But more recently, we are doing massive testing ourselves. So since Sunday, we've done 430 tests in large congregate spaces. And today, in fact, starting yesterday and today, we're getting results in about 8 hours from the state and doing reading of results. One thing that's important to note is in these large shelter settings, the reading of results is a very intense process that requires a great deal of support of the staff, especially considering that the staff themselves are also being tested. Some of them are positive. So quickly, just some of the challenge that remain, we continue to find less access to isolation units than we really need. And so we've found that positive homeless people are needing to stay in congregate settings, and we're working closely with those shelters to try to find separate spaces. Sometimes there's a room or something like this, but that is weighing on me personally. A lot of difficulty transporting people to isolation when it is available, and having to rely on some solutions that are, less than what you would expect in a large developed city, really pretty remarkable. And a lack of coordination in general. So we've got great people doing great things all day long, 7 days a week, but we don't have a homeless czar in Chicago. We don't have a single person who's really pulling together the homeless system, and we're feeling some pain from that. And we still need a more clear plan for the encampment dwellers and how to test and deal with that group. And we also are finding that people with behavioral health disorders are being screened out of isolation centers because of their behavioral health need, but not really with an alternative for them. So they're struggling within the COVID positive shelter, and we're trying to find some solutions for that. So I want to be mindful of the time, and so I will stop there, and I'm sure that there will be questions later too. But thanks for listening to me.
Great, thank you very much, Ed, and we appreciate all the work that you and your staff at Heartland Alliance Health are doing for the homeless of Chicago. We really appreciate it. So as we move out west, we've gone from Miami to New York to Chicago, and now we're moving to the great state of Wyoming. And we're going to hear from Dr. Beth Robitaille from the Wyoming Medical Center. So Beth, are you with us?
Yes, thank you. So just to tell you a little bit about our organization here, we are the Educational Health Center of Wyoming, which is a co-applicant model for our FQHC with a partnership with the University of Wyoming. We have 3 sites across our state, one in Casper and another in Cheyenne, which are our 2 largest communities in the state. And those 2 are affiliated with family medicine residency programs. And then a third smaller clinic in Laramie, Wyoming, which is where our university is based. So just a little bit about the state of Wyoming. We have a total population in the state of about 500,000. And so Casper, Cheyenne, and Laramie, the sites of our clinics, make up about, about a third of that population. As far as right now, some COVID statistics for the state of Wyoming, the whole state has performed only about 7,400 tests, and we currently have 322 confirmed positives and maybe another 120 or so probable cases. We only have 6 deaths. Actually, before yesterday, we only had 2 deaths. So it tripled yesterday. So our current rate of positives of the number testing is about 10%. We still have a couple counties that have no cases at all, and then many of our more densely populated counties just have less than 5 cases. I guess the way that I was kind of thinking about this presentation was to go through what I feel like are maybe the pros and cons of being in a rural frontier location during the time of COVID. So I've already mentioned that one of our pros is that we're less densely populated to begin with. We have a lot of open space around here. There's about 1 square mile per person. And when the social distancing recommendations came out for to be 6 feet apart, the most common comment you heard around here was that seemed really close to be that only 6 feet away from people. So we're made up of a lot of small communities, and the whole state of Wyoming really is often refer to as one big small town. Everyone kind of knows everyone, which I think has been helpful during this time to really coordinate efforts. So for instance, in my hometown of Casper is where I'm located. We have, I think, really been able to coordinate quite a bit of care because we are so small and we've worked with each other. And honestly, everyone's kind of related to each other. So we've been able to develop a centralized testing for our community that is manned by our Wyoming Medical Center, but is partnered with our county health department. And very quickly, we're able to arrange on-site testing for our nursing homes, homeless shelter, and assisted livings through outreach from one of our infectious disease doctors who also happens to be my brother. The county health department leader is a person that we went to high school with and we have worked with for 20 years, and she previously worked with our HIV and AIDS program for the state, so we already had a relationship with that. And then there's been a lot of work with our school district in providing overflow sites, and again, everybody's just connected. We also, in our clinic, we are really the largest geriatric provider in our community, so there was early outreach to us and our geriatric providers to help lock down the nursing homes and quickly convert to telehealth for our care there. And that was with one of my partners, Dr. Cindy Works, who is one of the faculty here. And that has seemed to be really pretty successful. We were also, as a big but small state, we are the referral center for much of the state here. And so when people get very sick in our small towns, they are referred to our hospital. And one of our first outbreaks in our state was at an assisted living facility in a town called Riverton, Wyoming, which is located on the border of the Wind River Reservation. And so very quickly, we were able to work with the doctors and communicate with the tribal leaders about social distancing, try to respect their culture as far as how their loved ones may be cared for in the hospitals, and kind of the social distancing, which would be probably really challenging for their culture, where normally family and being together is a big part of who they are. And again, with relationships, we were able to communicate very easily with that. I think another benefit of being in a rural area is that we are able to have, we know all of our leaders and very quickly able to get involved in some of the decision making in our communities. I'm able to participate on a daily call with our county leaders that has not only the county health officer, but our sheriff and school district and city council, police, all of that, and really get to be well informed every day. We also are able to serve and attend, I think there are about 3 times a week now, meetings at our hospital that are talking about all the changes that are happening. So I feel like we have, at least in our community of Casper, opportunity to really be very informed in the big picture of things. I think another big pro has been we've had more time than those of you in urban communities to prepare. And in some ways, I think we're maybe more anxious than you larger communities that have really lived COVID much more than we have. We still have a lot of anxiety as to what it will look like because we've not dealt with it a whole lot yet. And so we've been able to learn from you. Other positives, I would say, because we are a rural state, we have a program that called the Wyoming Telehealth Network that provided free Zoom licenses to all of us. So that was free and easy. That telenetwork office is actually housed at our college at the university. So again, very easy to do that. And we, just like everyone else, were able to get up and going with telehealth very quickly, but having over 40 residents to get signed up, that was pretty complicated for us, but it was successful. We are also part of the University of Washington WWAMI network, which is the medical school system for this region of the country. And we have had access to all their resources, which are actually public as well. But since Washington was really where things started, they had a lot to share and a lot for us to learn from. Finally, I would say this isn't necessarily being rural, but because we're also an educational facility, that we have benefited from being affiliated with the ACGME, which is the National Graduate Medical Education Accrediting Body, that has provided a lot of resources on how not only just to care for patients, but also how do you adjust resident education experiences during this COVID, how do you keep your residents safe, et cetera. Some cons, I think, that are probably not universal to all rural areas, but probably pretty common, at least in this part of the country, is that there is a strong, very strong commitment to individual rights, probably over the rights of many. So that strong independence sometimes doesn't mesh all that well with public health. Our state has never gone on any official lockdown or shelter in place, which I think a lot of us in the healthcare world have been pretty frustrated because except within our buildings, that it seems very much business like normal. We have pretty limited expertise and resources to start with. And so although we are very connected, we only have one level of things. So for instance, in our community of Casper, we have one homeless shelter. So if there are cases there, we're really scrambling to find what do we do next. We also have very small public health departments, and sometimes it's just 2 or 3 people that run those departments having to deal with obviously a big issue. I think one of the biggest things that we deal with in our rural part of the country is a lot of denial and complacency because we have not been as severely hit as the urban areas on the coast, and because people in rural areas tend to really not necessarily look to see what's going on with the rest of the country. There's been a lot of denial and complacency, and we're also a pretty red state, and there's been a lot of conspiracy theories going around as well. Being small, one cluster can really cause a lot of problems. So in our community of Casper, our inpatient psychiatric facility, which really serves much of the state, is our main cluster that we've had. 2/3 of the cases in our county are affiliated with that facility. And then I kind of call it the Kevin Bacon effect. That one cluster has spread across the state. So for instance, an adolescent that was at that psych facility and was asymptomatic was transferred to our juvenile detention center, and then he turned positive about a week later. One of our very rural communities of Thermopolis, which is a few hours away from us, had a patient discharged from that facility as well and became symptomatic after discharge, was tested in his community, and when he was relayed his results, he was in a third community of Riverton at the Walmart when he heard his positive results, so not a whole lot of self-isolation. Also, patients from that facility were then discharged to our state hospital in a town called Evanston, Wyoming, which is in the southwest corner of our state, and 2 of the patients ended up being positive there as well. And then we had some employees that work at that facility be positive, and they often, nurses and CNAs and things are working at multiple community organizations, other assisted livings and nursing homes. And we actually made the Washington Post last week because an employee who was notified that she was positive on Friday before the Easter weekend was caught on video on Facebook going to multiple parties over the weekend, even though she knew that she was COVID positive. And that has brought up a lot of questions of how do you enforce social distancing and what are, again, individual rights over the public rights. Some other cons that have been difficult, I mentioned a little bit of how it has affected resident education in urban communities like New York and Chicago. The resident physicians have been extremely busy, kind of really raising the bar to fill all the gaps and take care of the patients, and in that sense, really stepping up. In areas like ours, our residents are ready to step up, but we are actually seeing less patients in person, and they're getting their rotations canceled because of social distancing and things and limited PPE. And so we're kind of struggling to find worthwhile educational activities for them to do until our surge comes. We also, I think what's unique about us being a residency is that we also take care of our patients in the hospital, and we take care of the homeless clinic patients in the hospital, VA patients, et cetera. And part of our planning has not been just how can we take care of our patients in the outpatient setting, but it's also preparing for the surge and what role we'll play in the hospital if it really gets as busy as anticipated. And balancing those different needs has maybe been unique for us. As far as testing goes, another con of being in a rural state is that test supplies and PPE they're short for everybody, I know, but we got very little for our entire 3-clinic organization. We maybe had 75 tests to use, and we actually ended up donating the vast majority of those to our local hospital and health department so that they could split the biomedia and use it more wisely or more effectively. So we aren't actually doing any testing in our facilities at this time because we don't have the testing materials, and we also don't have the PPE to really sustain any worthwhile testing capabilities. We also aren't seeing any respiratory patients in person. We're doing all of that via telehealth, again, because of limited PPE. And, those supplies are really going to the hard-hit areas, which totally makes sense, but it has been a challenge for us. I've talked a lot about how it is in my community of Casper, which I think has been an overall a very positive coordinated effort. The communities where our 2 other clinics lie in Cheyenne and Laramie, I don't think there's been as coordinated efforts. People there do not have access to easy testing. It is mainly being done at urgent cares who are charging $400 or $500 for the tests. The hospitals in those communities are only testing their patients who are admitted to the hospital and their own employees. So even getting testing for healthcare workers in the community has been challenging, or at least affordable, easy access. And so I worry that there's, when things get worse, or when and if things get worse, that things could really spiral out of control in those communities. So I guess one last thing I forgot to mention earlier, what were the demographics as we talked about vulnerable populations. Of those 322 confirmed positives, 64% are Caucasian, 13% Hispanic, and 12% Native American, which those are disproportionate amounts for those minorities than our overall population in the state. So all those same factors that other speakers have talked about has been pretty significant. Our Wind River Reservation is especially vulnerable because of that outbreak in their neighboring community. And there is limited resources on doing a lot of the contact tracing. So there are suspected large numbers of positive cases on the reservation, but just not the ability to really test and track and manage that. So I will probably wrap it up now. Thank you.
Beth, thank you so very much for sharing your experience both in the state of Wyoming and then also at the Wyoming Medical Center. Some real challenging things that you are experiencing, and everyone wants to let everyone know we're all family here in the Community Health Center movement. We're moving through this together, having some different experiences, and that's one of the reasons why we're doing these webinars so that we can both speak our experience, share our experience, and learn from each other's experiences. So again, thank you very much, Beth. So our next interactive poll, again, using your cell phone, texting 22333 and putting in the subject line COVID-19 heroes, you'll get a response back. And the question is, how many millions of foreign-born workers are in industries hardest hit by the fight against COVID-19? So again, how many millions of foreign-born workers are in industries hardest hit by the fight against COVID-19? We have 8 million, 6 million, 4 million, or 3 million. And as we give it just a few more moments to let some of the responses come in, we've had about 260 people on the webinar so far, and we really appreciate your time. We know taking an hour and a half out of every week is significant, but it is very valuable for health centers to hear from each other. So we really, really appreciate it. So as we close this last poll, the answer is 6 million. So 6 million foreign-born workers are in industry hardest hit by the COVID-19. That's according to MPI. And so as many of us are hearing about migrant workers across the country and how this is challenging, we're next going to hear from our partners out in California, and Blaine is going to talk to us about the experience of Salud para la Gente. So Blaine, are you with us?
I'm here. Can you hear me okay?
Yes, perfectly.
Okay, great. So yeah, I'm coming at it from a slightly different angle. I'm the director of IT and data systems, so I'm in charge of the health IT systems, which includes all of the EMR, EHR systems, as well as all the infrastructure. And then I also have with me Darlene Torres, who's our community health services manager. A lot of what has already been addressed, we're doing the same thing. We're FQHC at the nexus of 4 different counties, 3 of which are highly agricultural. So we do have a set of large agricultural in 3 of those. We have the Salinas Valley, the Watsonville community, and then of course Santa Cruz. The Salinas Valley being the salad bowl of California. And within that community, we have all of the leafy greens community. We also have in Watsonville all of the berries and strawberries in this community. We have a very large agricultural community in that, a ton of migrant communities, as well as the groups that historically go back and forth between northern Mexico, Yuma, and then into California. So this is a very large vulnerable population that Darlene will address what we're doing in that area. On my side of the house, one of the areas that we initially addressed within our core team and then our senior leadership team was early on identifying gaps in communication and collaboration between the agribusiness sector and our public health, as well as the community hospital. Our leader, our president, Dori Rose Indra, went out and addressed this because we have currently about 13,000 patients who are agricultural workers within that with agricultural worker dependents within the Watsonville and Salinas area in the Monterey County and the Watsonville County areas. So we went out and actually aligned with the specific agricultural organizations, public health, Santa Cruz County, and the community hospital to work on putting in best practices within those groups, as well as aligning direct communication, so that we would have that, that direct communication and collaboration working with those groups. A lot of these communities, as you know, we're dealing with historically large multifamily households, groups that may not have the ability to do the separations that are necessary, as well as groups that may not be able to hear the communication that we're putting out in their languages, as well as we do have some unique challenges with literacy and language groups for a Mixteco population, which are indigenous populations from Mexico that aren't speaking Spanish or English. They're speaking a combination of the Mixtec language. So getting that communication out to them in their actual language. And again, that will be addressed more by Darlene with what we're doing. On the IT and data systems side, which is more unique to my realm, we're quietly working in the background to facilitate all the different things that we talked about earlier on. And you can go to the next slide on that one. So we addressed exactly what are we dealing with for what might affect the, our actual migrant workers and population. And part of that was going through and making sure that we were able to facilitate what was needed actually out in our facilities. So we started addressing what are we going to need actually at the clinic spaces, what are we going to need for communication. So we worked with the different groups to make sure that we actually had things such as the telehealth systems and programs. What did we need to make sure that we were going to be there for these different groups? So part of it from an IT perspective was spooling up telehealth as rapidly as possible. For that, you can go to the next slide. We worked on the hospital partnerships, aligning on the protocols, the communications, and the business arrangements. We worked on aligning medical providers and the education, especially regarding to social distancing and the tracking and tracing of people. This is one of the scenarios where working with the actual agribusiness alignment, and I didn't actually mention this, but I have 25 years of agribusiness experience working with different groups. I was the vice president of Earthbound Farm for 25 years before lateraling into education. One of the things doing at the field level was keeping track of the actual field workers, which tractors they were on, which buses they were on, keeping track of as we're going through in case anyone actually tested positive, and communicating with them, temperature tracking and the rest, even though, of course, that's we're tracking it as they're already showing symptoms at that point. Still being able to keep track of which folks are going in, where they're being clocked in and out, which guarding areas, communicating with the agribusiness groups where they may not be thinking about this themselves. And if they have on-site clinics, educating and communicating with those specific groups. So really getting in as deep as possible so that if there is an actual, scenario, trying to avoid the actual tipping point per outbreak and knowing where people are flowing, which is extremely difficult when you're dealing with 1,500 to 1,800 people, changing shifts, working multiple shifts, or if you have people that are working, shifts that normally aren't there. So trying to get that level of communication and working with the operation groups within those different, processing teams. So, and then of course, working with your different public health alignments. With us, it's primarily Santa Cruz, but focusing on the prevention and coordination, as well as aligning on the usual social determinants of health aspects. But as one of our colleagues mentioned earlier, going beyond that as much as possible, but still making sure that we have the primary food, housing. We also offer legal services in this time that's also critical. And then focusing also on comorbidities, which we'll get into a little later. One of the things we did have to do on the IT side was, along with focusing on getting telehealth up and running, facilitating social distancing. And go ahead and go to the next slide, and I'll address it there. Zoom for healthcare. One of the items we had to do was use Zoom for healthcare in a couple of different ways. One was making sure that we had the capability of getting that spooled up as rapidly as possible for our provider base. The reason we went with Zoom was we're dealing with a scenario where we have the HIPAA compliant version of Zoom. We had it staged minimally for base use within our system. But the reason we went with that on a larger scale was its user base and the simplicity. We don't actually have to have users who have accounts logged in. For them, we can send them a simple link. They click on it, they're joined in. They don't actually have to load a client. We're trying to get patients to just use the link, don't load an app, don't create an account. Just keep it as simple as possible for our users. On our side, We have the providers already set up. We're handling that in IT and data systems. So we're trying to make it as simple as possible so we can focus on care. We're distributing it to them using our Well SMS text messaging system. Now, luckily, we already had this system in place with a very high adoption by our patient base. So we got a little bit of a jump start on that. So for the most part, we can communicate with a secure SMS message, which keeps everything internal. Our providers are able to send that out through our SMS message system. The patient clicks the message on Zoom and is able to attend the session. So for the most part, that's working out well. And we're using it in a fairly minimal session right now, focused on behavioral health, and then rolling that out as needed for our lactation services, and then also for SUDS and MAT as needed, and then working into anything with public health as needed for anyone who will be COVID positive and then is going to be in an area where they cannot come into the clinic. So we're doing it only as needed, focusing on telephone first services and then rolling into additional medical services ramping up, again, as needed. But so far, this is working out well for us and with minimal training. But it is still a challenge. No matter what you're doing, it is a challenge, and really working on the clinical care aspects. And that's where, focusing on the infrastructure side, the facilitating of the systems, and then also where are those different levels of clinical care necessary for handoffs, for working with different levels of translation services bringing in, and then for my group also working with the different providers, the clinicians, the patient advocates for what the workflows and the training of work, because that's also under my umbrella. So the whole total care aspect is quite a challenge. Also trying to encourage social distancing. So we were actually going through at the IT side and quietly breaking computers to enforce that every computer and every other cubicle was disconnected at the data system side with a sign on it to enforce that only computers every 6 feet apart were active. And then also launching a system where we doubled the capacity of our VPN capability to get every essential worker who was essential, who didn't need to be in the facility, to work from home. So we're quietly launching a few levers to get people to go away. You can work just fine from home, stay away, to make sure that we actually were going to be able to survive, to be available to those vulnerable populations. If you think you can work and you can, let's keep working, but let's do it from a safe distance. So we're just kind of putting a few levers out there. So that's everything that we were doing, as well as launching our mobile drive up just for temperature taking, getting the tents in place, doing everything, because in those tents, you have to have the equipment to be able to do it. So one of the things we also wanted to do is we were actually using clipboards and paper. We did not want that paper coming back into the actual clinic. So for that, we were implementing what's known as RX Photo. We utilized RX Photo to actually take the paper charts, go through, take a photo of those charts and have that delivered directly into the EHR with the patient's information. And then the paper stayed outside and was immediately destroyed, shredded, and put into the pickup bin, so that none of the paper that could have been touched by a patient made it into the clinic, trying to keep that literal physical separation, outside by the car, never comes into the clinic, just trying to keep that thought process, and how do we facilitate that using an IT mentality to deal with that. The other thing we did is we dedicated one of our clinics to focus on high-risk patients with potential comorbidities and really focus on outreach to them. So it was a rapid spool up of additional hardware systems, technology, and bandwidth to make sure that we had that capability. And for that, I think I'll hand that off then over to Darlene so she can address what we're really doing to make a difference with our patient base. And Darlene, are you unmuted?
Okay, there we go. Hi, everyone. Thank you so much. I've learned a lot about what the other states have been doing, and it's exciting to learn what things that we could potentially change at our clinic. I wanted to talk a little bit about our vulnerable populations. We have created what we're calling our Valle Verde outreach site. And really what we're doing is we're focusing on this vulnerable client and we're wanting to make sure that they understand the importance of social distancing, as well as provide them with education about how to manage their care during this time. Our first registry that we focused on was our diabetes management group, and we actually were able to get a hold of 1,887 patients in 2 weeks. So we had a team of about 15 medical assistants making calls, and 85% of those were patients who were identified as being comorbid with things such as hypertension, obesity, and depression. And 21% of that registry had identified as having 5 or more people in their household, or even having about 3 or 4 people living in one bedroom. Of those patients, we were able to make 324 telehealth appointments. And so we really identified how important this was. We were also able to make over 600 referrals to our community health services to identify other social determinants of the health resources that we could provide for these patients. The second group that we focused on, and we're currently working on, this is day 4, is our Pulmonary Registry, and we've called about 1,128 patients, and most of them have also been identified as having more than one diagnosis, which includes depression and hypertension. 30% of those individuals have identified as having a home of 5 or more people, again with the same thing where there may be multiple families living in each of the rooms. We found that 119 appointments have been made. Now we're also offering different kinds of courses as far as food distribution. We've been able to provide things such as food deliveries to people who may not have qualified previously. And we're also providing other resources that I'll speak further on in another slide. As of 4/21, we have provided a medication distribution center here at the call center for both patients to pick up medication, as well as a delivery service for those patients who are, again, identified as being vulnerable, and it would be best for them to stay at home. Next slide, please. For those patients who have identified as having concerns with self-isolation and have been tested positive, we have been providing programs where they're able to self-isolate in hotels at a reduced fee or free based on what their need is. And so that has been helpful because, again, a lot of our families are farm worker families. And so multiple groups of people are living under the same roof. So it's kind of difficult to self-isolate when there's 5 people living in a bedroom. And then again, another bedroom may have 3 or 4 people living in it as well. So that being a big issue here in Watsonville, California, we thought it would be important to be able to provide self-isolation for those who may need it. Next slide, please. Some of the other clinical outreach that we have been doing, I did mention food distribution. We have several food distribution sites through Salud para la Gente at our 2 primary clinics. And then also, as mentioned, we have food delivery service provided to our patients who may have tested positive. And that way we're really limiting the contact that they're having with the community. For our undocumented patients who may not qualify for things such as Social Security or unemployment and disability and are not working in the fields right now, we did come up with a grant that provides $27,000 to patients who may need additional assistance with food, medications, paying some of their utility bills. They are offered anywhere from $100 to $500. It's a one-time gift to that patient in order to kind of help support them in their household. We also do have the Watsonville Law Center as a partner who is able to help us with some of those complicated cases where the patient is concerned about applying for disability or food stamps or whatever the case may be because of their status or where they're at in the process of becoming a citizen. And so they're able to do that at free of cost. We have several application assistant programs as well, where patients are getting their medications free or at a very limited, maybe $5 or $4 for the medication that they're being provided. And again, we have various SDOH referrals that identify things such as housing. If housing is an issue, we have a housing case manager on site who's able to help and support patients with different opportunities that they may qualify for as far as housing is concerned. Again, food insecurity being one of the biggest ones, as well as medications. There is other issues that are being brought up during our SDOH assessment. And so based on patients' needs, we're able to provide them with as many resources that the community can offer. And along with that, those patients who are farm workers right now and are working Monday through Saturday, we identified that it's important to still be able to have access to care. So Salud para la Gente has extended their hours and days to include Sunday. So we're open currently 4 hours on Sunday for patients who do not want to miss work during the week. And it's still important for them to be seen either in the clinic or to be able to be ready to start a telehealth visit with our patient, with our providers on a Sunday. We will be starting an extended day on Sunday, which would be 8 to 5 o'clock, and that starts next month. So we really are trying to focus on what we can do to identify the needs of the farm worker community and help support them obtain the health care that they need. And I don't know if that's my last slide.
Great. So thank you very much, Blaine and Darlene. We really appreciate that perspective, and hope that the health center and your patients are doing well. So as we conclude today's webinar, we want to thank everyone who was able to give their experience to others across the country. We want to thank Health Choice Network and Alliance Chicago for hosting these series. On the next couple of slides, we do have some resources. You can scan your phone to get the resource library from Health Choice Network and or Alliance Chicago. Please use the hyperlink. This slide deck will be available later today. We will email this out to all registrants. And as we close today's session, from our word cloud that we began with, what's one new successful intervention that your health center has done this week for COVID-19? So it looks like there's a lot of testing, drive-through pharmacy, telehealth, telemanual testing, telehealth. So again, on behalf of Health Choice Network and Alliance Chicago, I'm Tim Long, and we thank you for joining today's webinar, and we'll be seeing you shortly. Thank you for the healthcare heroes across the country who are doing all of this work. Have a great day, everybody.